Hi friends, come with me to get an occipital nerve block and trigger point injections for my migraines and occipital neuralgia. So the migraine that I had lasted for about 3 days. I used all of my at-home rescue medications to the emergency room, which was awful. Really nothing was touching this freaking migraine. So whenever I get migraines like this, what usually brings my pain down to like a 0 is the trigger point injections.
We're taking care of Brittany again today. She has chronically poor posture, which means that she ends up with some occipital neuralgia, that is to say, some difficulty with the nerves of C2 and C3 as they go up into the back of her head, possibly triggering her migraines. She also has some tension that is chronic because of her poor posture in the trapezius, the semispinalis, and the splenius capitis muscles. Today we're going to be doing a combination of an occipital nerve block that can be done at the same time that we do trigger point injections. This is me going into the attachment of the trapezius to the base of the skull, where she has a lot of point tenderness, and from that point I'm going to move up just a touch and inject right into or along the base of the skull where the occipital nerves traverse the base of the skull, causing pain, again in her case acting as a trigger for her migraines. I'm going to move the needle just a little bit to continue to address the entire area along the base of the skull with the injection solution. Now I'm addressing the semispinalis muscle, again attaches to the base of the skull with a lot of inflammation and a lot of tenderness in the setting of poor posture. It's really going to be an important piece of Brittany's rehab to aggressively undergo physical therapy and for her to really dedicate herself to fundamentally changing her posture. Going to be the more lateral component of the occipital nerve block, which you'll see me going up into the hairline with. The last injections here are going to be trigger point injections into areas of spasm. I'm now addressing the top portion of the splenius capitis, where I've already palpated areas of spasm, again in the setting of her poor posture, which is a very, very important trigger for her chronic migraines. Starting with the attachment of the trapezius, once again going up into the occipital nerve block and working my way across from left to right to the semispinalis, followed by the splenius capitis. Here I'm trying to isolate muscles in her left shoulder that seem to be problematic, and I've identified a large area of spasm, a big knot in her levator scapula. I'm using the remainder of my injection directly into an area of hard spasm, and she'll feel immediate relief with the local anesthetic short-circuiting the connection of pain in the muscle to a need to tighten up to protect it, as well as a touch of Toradol and a touch of steroid. Great procedure. I love it.
That's so fun. I'm so happy I could like cry. Oh my god. There's like nothing more frustrating than like nothing working.
I hear you.
Hey, thank you, Dr. Prieto.
You're so welcome. I am just glad. Going over the medications that are included in the injections that I did for Brittany today, which are occipital nerve blocks as well as muscle trigger point injections. I use bacteriostatic sodium chloride to dilute a long-acting anesthetic, local anesthetic called ropivacaine, which is very effective and can last for several hours. Additionally, I like to add to achieve longer-acting results and provide ongoing anti-inflammatory effects, Toradol, which is an NSAID or anti-inflammatory very similar to ibuprofen but much, much more potent, as well as dexamethasone. I'll use a small amount of this steroid to provide longer-acting anti-inflammatory effects, particularly for the muscle trigger points, but it also can enhance and lengthen the effects of the local anesthetic in the occipital nerve block. Obviously, I use syringes, I use aseptic technique, and these techniques are very safe and very effective in treating patients like Brittany, whose triggers for her migraines may be based in muscle spasm as well as occipital neuralgia.